Okay. So when we see patients like the 6-year-old, and we see another young gentleman with numerous lesions on his chest, and one with several lesions on his shoulder, and this elderly female with this widespread keloids, we can basically come to a conclusion that not one method of treatment is going to take care of all these patients. And we need to have more than one method of treatment for these patients. So in deciding how to treat these patients, we need to consider the stage of the keloid, prior treatments the patients have had, location of the keloids. Obviously, you don't want to repeat what has been done previously to these patients. Also need to take into consideration patient's age, location, morphology, prior treatments, and pace of the disease and how rapidly this disease is progressing, as well as response to prior treatments. This was a staging system I designed in 2016 that categorizes patients depending on some of the largest lesions that they have, some of the largest diameter of the lesions they have on their skin. So we start with very early stage small keloids, keloid papules basically. For these keloid lesions, something like this, a lot of young patients start just like this with a papule on their chest because of the acne. It's extremely important to manage this aggressively upfront, try to induce a remission before it turns into something more serious. I cannot overemphasize this. So this is a very, very early stage. And this patient was treated with intralesional triamcinolone with cryotherapy at the same time, and we induced a complete remission in that. This is another patient with kind of more advanced keloid on her chest. I want you to pay attention to the two tiny spots you see above and below this larger keloid. All of these lesions were treated with cryotherapy. Forget about the larger lesion, that didn't do so well, but the tiny lesions, the one especially in the lower part of the chest, you can see that this has completely disappeared. So managing these tinier ones, smaller ones, is a lot easier. And if you control that, hopefully it doesn't get to these larger keloids. And all these larger keloids, all of them start there. So what's the rationale in treatment? And this is another example that I want to share with you. This is a 20-year-old female who presented in 2012. And I'm going to show you 13 years follow-up on this patient. She presented with these two small lesions on her chest, and this one in the middle that has a linear line in it. And the one in the middle was previously surgically removed. And the other two basically had not been treated. She presented in May, was doctor shopping, and then later on came and provided the history. She had had this for 2 years, came back after first surgery that she has had. She has had several steroid injections, and actually there's a positive family history there as well. These two were previously untreated. This one was previously excised and relapsed despite steroid injections. So I treated all of these with the same thing, steroid injection that she has had previously plus cryotherapy. And we're going to look at the follow-up of this patient over the next several years from 2012. In 2013, the two lesions that were not previously treated surgically, they started responding. The one that was previously treated with surgery didn't. And this is 2017, 5 years later. As you can see, the lesion that was operated on is bigger, despite the fact of having received the same exact treatment as the other lesions have done. Same follow-up, 2019, the lesion that was operated previously on has gotten worse. This is despite treatment. I've thrown everything I know on this one lesion that never responded. 2022, those who have not relapsed have remained in remission. This one continues to progress. And this is 2025. This is progressing despite all kinds of treatment. So from here, basically, there's a lesson to be learned here. The surgery in this one particular patient negatively impacted the biology of the disease to a point that lesions not touched, they responded to treatment very well. The one that was touched surgically basically did not respond to treatment. So you can basically, this is the conclusion I've drawn, that for early stage keloid lesions, we really need to avoid surgery because this would impact the biology of disease. This is another example of that. These patients don't wake up one day with these large keloids. They all have several years history of what have had. This patient has had 3 surgeries, radiation therapy to her ears, and we ask her, how did this whole thing start? And she had piercing of her ear several years earlier. This turned into a very small, tiny lesion on her earlobe. This was not treated in my opinion, properly, ended up being excised, regrew, excised, followed by radiation therapy. And from this, we ended up with this. So this is something we want to avoid, basically. We need to treat that small lesion on the ear and avoid this. And this rationale of avoiding surgery up front is supported with some data. And this data set you can contribute to support. So I look back at 283 patients whom I had treated in my practice, and we cataloged the keloids of these patients. Patients with very large keloids, call them massive because the keloids are bigger than the size of their ears. There were 13 patients. Semi-massive, they were a little bit smaller than the size of the whole ear, but bigger than half of the size of the ear. There were 18 patients there. Medium size, this was bigger than this. This is very arbitrary classification. And 71 patients with very early stage keloid lesions. And basically, this is the percentage of these patients. Almost 10% had this massive and semi-massive keloids. I mean, look at them. 100% of patients who had massive ear, 100% of patients who had semi-massive had prior surgeries before, and 72% of patients with large ear keloids. So when you look at the p-values here, they're off the chart. This tells you there's a correlation, direct correlation, is statistically supported with prior surgery and worsening of these keloids. Same data applies to the patients who have large keloids, massive, semi-massive, large, and smaller neck keloids. And we look at that, about 20% have massive, about 18% have semi-massive. And here there were 1 or 2 patients who did not have surgery before, majority did. And again, the p-values are off the chart, 0.0001. So there is a direct correlation with worsening. This is another example. This is a patient who's 24 years old, presented in 2017 with this massive keloid. And we're not going to take this patient to a TV show and show what we can do surgically with this. Just going to ask him what happened. How did we get here? So 2 years earlier, just a bit in December 2014, and that was February 2017, 2 years and 3 months later, he had these small keloids in his neck that were surgically removed twice. And that's what we ended up with. So we need to treat these. We need to prevent that. And this is another side effect and issue related to surgery, loss of earlobe tissue, and loss of anatomy of the ear. This is by no means any success. So we need to treat these. We need to avoid all of these complications. I did a survey on keloid patients who have had surgery without considering any other factor, and about 56% of them tell them the keloids get worse after surgery. So for basically, to understand this is a disease that has a pathology that is widespread to the skin, and surgical excision carries the risk of worsening of it. So we talked about papules, very early stage to avoid surgery. The next would be nodules. So this is how we organize the strategy in treating them. Patients with, and again, most of this strategy is non-surgical. Patients with nodules, keloidal nodules or small tumors, they should be treated basically with cryotherapy first to see you can achieve a response before we put a knife on their neck, on their skin, or in this case, on his neck. With one course of cryotherapy, you were able to induce a complete remission that has been durable ever since. And how is cryotherapy done? It's treatment of choice basically for all ear keloids, all most bulky keloids. This is an example of an ear keloid that was previously treated, that was previously untreated, of fear of getting worse, treated with cryotherapy. You repeat your treatment 2 or 3 times until you achieve complete remission. This is another example of an ear keloid that was treated with cryotherapy only. And you can achieve decent results with a very simple method, not running your risk of making these any worse. Triamcinolone has its role. It's a first-line treatment for most flat and small keloids. I'm not quite sure that induces 50% complete durable remission. I haven't seen that. You induce some sort of remission that is not durable, and patients usually have recurrence. It's perhaps most appropriate for patients who present with tiny, small lesions that are due to acne, wherever it is under skin. At least you need to try that once. The questions that remain are, what's the proper dose of steroids? We have some presentation that will come and talk about, we're maybe using a lot higher dose of steroid than we should. How effective is it? How safe it is? So all of these need to be addressed. again, what we are doing, we're using very empirical dosage of this. Everybody uses whatever dose they wish. We don't have harmony in that. And actually, there's no linear relationship between the dose and response. And the assumption is higher dose works better. Of course, it does cause complications. This is an example of how this one patient with post-autoplastic ear keloid has been treated with triamcinolone, a 40 milligram, 1 cc of it given almost every month. You do that once or twice and you don't see a response, you just should stop. Do something different. It doesn't make sense to keep repeating it 10 times. I'd put 340 milligrams of triamcinolone in this ear keloid with absolutely no response. You do it once and stop if it didn't respond. And this is not a keloid that you can treat with steroid injection. This patient, the dermatologist injected 2 whole vials of triamcinolone into this large keloid. And patient basically stopped it because she didn't see a response. If you add up the dosage of the patient, she got up to anywhere between 600 to 2,400 milligrams of triamcinolone. And patient stopped because there was no response and her face started swelling up. And we do see some systemic side effects from injection of triamcinolone when we use these high doses. Obviously, Cushing's syndrome is one. We ran a survey on a large survey, which at some point later during this meeting, I'll share some information about that with you. About 1,100 patients in this survey had responded to this, and a large number of them had received steroid injections. And you ask them how basic, that's 846 patients who had received steroid injections. And you ask these patients, how did you respond to steroids? All of it is good. The response rate, that true response rate, the patient kind of the cure was about 1%. 32% they tell you the keloid got better. Almost 50% tell you it didn't make any difference. The issue is here. 17% tell you the keloid got worse. Keloid got worse. This is something that's unreported in the medical literature other than this publication. The dose that I use is basically, I don't use Keloid 40. If you look at the package insert of Keloid 40, it says it's not for dermatological use. So read the package insert. I use a Keloid 10. I even diluted 1 to 5 and then inject the keloid lesions with trying to find the minimum effective dose. I use the smallest size gauge needle there is. Once you use steroids and it doesn't work, you basically need to use something else. You try steroid once, twice at most. If you don't see a response, you need to add intralesional chemotherapy to that. And these are some examples of patients who have responded to intralesional chemotherapy. Basically, you can induce a decent remission just with repeated every 3 to 4 weeks of, we'll go through different drugs, intralesional chemotherapy. That's not only 5-FU, but if patients don't respond to 5-FU, something else. These are other examples of the responses you can achieve with the strategy of Kenalog. It didn't work. You basically add your chemotherapy drugs to that. So these are responses that you can achieve with intralesional chemotherapy in a fairly short period of time. Not everybody, of course, is sensitive to that. There is role for surgery. Unfortunately, the role is here. For patients who have had prior surgery, whose keloids have gotten worse, you would never see this as a de novo keloid. These are patients whose very early stage keloids have been treated with surgery, who have ended up with these very massive and large keloids. Now we are left with what? I mean, you cannot use cryo or intralesional chemo or anything on these. So you end up resecting these and then follow that either with radiation therapy or something else. So I use in my practice intralesional, call it intralesional or post-op adjuvant intracicatricial injection of the chemotherapy drugs. And you can basically induce some sort of decent remission. This is an example of a patient who had 2 C-sections. This was basically the second keloid that had grown after C-section. You knew that if you remove this surgically, it's going to regrow. I had done it twice. So we had that removed surgically again, but this time followed it with basically incisional line of chemotherapy drugs, and we were able to induce a decent remission. And this has been to this date persistently under remission. This patient is a physician herself. She follows with me for some other keloid that she has after cholecystectomy. We need topical treatments. Dr. Yap is developing one. I have a combination of 4 different anti-inflammatory drugs that a local pharmacy puts together for me. And some patients, somewhere about 5-10% of patients respond to that. When you deal with a keloid this big, this large, that goes across the chest, this is not something you can even inject It's extremely painful, extremely difficult to inject. You don't want to put this patient through another round of surgery and radiation therapy. You'll be using a very large field of radiation therapy. And luckily, she was responsive to the topical that we used. Lasers, I'm not a fan of lasers. In that survey study we had 182 patients who have received laser treatment. And some of these patients basically reported that the laser helps them. That percentage is quite low, rather. About 27%, they tell you the keloid gets better. The problem is here, 23% of patients, they tell you the keloid gets worse. And if you see lots of patients with keloids and you ask them, you will get to this. As some of your patients tell you the keloids got worse after laser treatment, no matter what laser treatment is. This data basically doesn't distinguish between types of lasers. So some of our patients need systemic treatment, perhaps need much better treatments for someone who presents like this. So we treat it. We need innovative treatments. We need drugs that we can introduce intravenously, orally. For patients like her, like him, we basically need systemic treatment. And unfortunately, this is where we have failed our patients. This was a review that was not made possible just by myself. It was done by my colleague, Dr. Tae-Hoon Park, and Albert, and another colleague, and Dr. Key here, who is here with us. So some of these guidelines you can find on the website of Keloid Research Foundation. A lot of guidelines that I discussed with you, this was a very brief presentation, are available on keloidresearchfoundation.org. You can access these, and a lot of information about keloid nomenclature, staging is also available. Thank you very much. Who is coming next? Your.
Should we have some questions now directly?
Sure.
Because, I mean, there must be so many questions to...
Absolutely. You can set up the next slides.
Yeah.
And you make us curious about your application.
And you're brave with so many plastic surgeons here saying, don't use any scalpel.
Dr. Tirgan, Michael, thank you very much. The audience must know that our famous Dr. Tirgan, who I respect and like a lot, is a medical oncologist. I'm called clinical oncologist. In other words, I'm also an oncologist, but I wear two hats. I give radiation and chemo. I'm allowed to. Now, where Dr. Tirgan does a disfavor to radiation is he just said, with an ear, failed radiation. But you didn't tell us the dose, didn't tell us the fractionation, the time, what sort of radiation, and that's not right. But you can't dismiss radiation just by calling it radiation. The same chemotherapy, you mentioned the drugs, the dose, and so on, but if you're a radiation therapist, just telling us failed radiation doesn't mean anything. You have to tell us the type of radiation, the fractionation. That's unfair to us, Michael.
Same comments for laser.
So, you're both absolutely correct. You're both absolutely correct. With respect to radiation and the dosage, etc., in this presentation, I didn't discuss much about radiation therapy.
You said the ear failed radiation, you said, and then succeeded.
One patient, correct. That's correct. That's absolutely correct.
That's what radiation was that was given that failed.
Absolutely.
Tomorrow we have a discussion on radiation.
We'll have plenty of discussions about radiation tomorrow. No, that's wonderful. With respect to laser as well, what I shared with you, it's a big survey that I ran, and patients know they receive laser treatment. They don't know what kind of laser they're receiving, but that is real data, that about almost 30%, 25, 30% of patients have worsening of the keloids with laser treatment. And when you see lots of keloid patients, you see these patients who have gotten worse after steroid. I mean, I don't know. Have you seen patients that the keloids has gotten worse after steroid injections?
I mean,
Where is it in literature?
Laser, there's fractional laser, I mean, ablative laser.
Absolutely.
So
You're absolutely correct. You're absolutely correct. As I said, that data does not distinguish with type of lasers. However, there was a Cochrane review of laser treatments a few years ago There was a Cochrane review of laser that's published based on reviewing all the literature there is on lasers. That Cochrane review found actually no evidence of efficacy of lasers, unfortunately.
In hypertrophic scarring, there is, but yeah. But this is keloids. You want to ask a question?
Just curious about the very, very small keloids. How do you know that's a keloid? Unless you have a patient that's already had other keloids, how could you tell from that little red bump that that was going to be a keloid? And I'm very curious.
You're very correct. So when a patient presents with an acne on their chest, like that young girl, these patients don't wake up one day with this. Initially, they think it is acne, but when it doesn't go away with acne treatment and sits there for 6 months and starts getting bigger and starts itching, that clinically tells you it is not acne anymore. It is, and what else could it be? Clinically, by looking at it, you know it is keloid. If you see enough keloid patients, you know that's a keloid. You should never biopsy that. The mistake is some physicians actually biopsy that to see what it is. Shouldn't be biopsying that. 18-year-old is not going to develop a lymphoma of the skin, and skin lymphoma, skin cancers don't appear like that. I mean, you're a dermatologist. You tell me when you see a lesion like that has been present in that patient, it was present for 2 years, right? What's your differential diagnosis on that?
Well, one would be fibrosarcoma protuberans. There are case reports of people being treated for keloids like 1 or 2 years, and it turned out to be a dermatofibrosarcoma protuberans, which is also a fibrotic tumor, but it's a malignant tumor. So that's maybe in the differential diagnosis, but otherwise, I don't think there's something else.
And they look different.
They do look different, but
And their stiffness is different.
Correct. And assume that is dermatofibrosarcoma. You treat it with intralesional steroids or intralesional chemo or cryo, it's going to progress. And it's going to then appear clinically different than a keloid lesion. And that patient, you notice you had 2 spots, another one had appeared. Dermatofibrosarcomas appear in one area. They're not like metastatic. You're not going to have 5 lesions.
I like the part about the 5FU. I think that's a great option. How do you manage birth control? How do you manage it with people who want to have children in the near future? Because this is the age group, and I find it difficult to make that trade-off. I always insist on contraception, but how do you do it with males? Like in the patient information leaflet, it says you have to even preserve sperm if you use it for cancer treatment. So that's a bit tricky.
So I have a whole lecture on intralesional chemotherapy, and I will be addressing a lot of them, I believe, tomorrow. However, you're absolutely correct. So this is a disease of youngsters. This is a disease of teenagers and basically early 20s, patients who are in the early 20s. And these patients should avoid becoming pregnant. You tell them not to become pregnant, use birth control. To male, no. To male, because the amount of drug that gets injected is extremely low. Metabolism of 5FU is extremely fast. It's a matter of minutes, basically. So it doesn't have systemic effect. I don't think it would impact on sperm cells. However, as a precaution, same as you tell young women that if you're pregnant, don't smoke or don't drink, this is same category. As far as safety of these drugs goes, a lot of cancer patients who receive full dose cancer chemotherapy drug, they become pregnant and deliver healthy babies. So it's not that we know this, and 5FU is not a carcinogen drug. So the precaution has to be given, but I had a patient who was receiving chemo, and then she didn't show up for 1 year, and she showed up happily saying, I just gave birth. I said, well, I told you not to become pregnant, but she becomes pregnant. You cannot fault her for that. But yes, that I always bring up to the patient's attention.
There's a question here.
Yeah.
The reason he knows it's got the experience with keloids. You're not a clinician. You said it often in your talk. We know it's not a sarcoma, it's a keloid.
Patient can go to somebody like you or so how do you tell?
Well, but you can tell through experience.
But not every patient has a doctor that's that experienced.
No, not every.
You are correct. Now, Dorothy has a point. I mean, you are correct. You're very correct. So who does the patient go to first? parents, family. I have this spot on my chest. That's all. It'll go away. A week passes, 2 weeks passes, 3. It doesn't go away. At the end, people have that much intelligence to go and see a dermatologist. They do. They go and see a dermatologist. They tell them something, whatever it is. Usually, these get injected with intralesional Kenalog up front by whoever who sees them. Usually, and again, there will be difference of opinion. And usually doesn't respond. And 6 months passes, 2 years passes, and that's still there. Then it is keloid and it's not active. Never, no. Yeah, never biopsy that. The question here, please.
So thank you very much for your talk, Dr. Tirgan. I have 2 questions. We all talk about cryotherapy and about intralesional injections, but what kind of protocol do you follow? Because when I ask my colleagues, everybody has a different protocol. So what kind of interval do you use?
So I use contact cryotherapy. These patients I showed you, they're all treated with contact cryotherapy. Frank showed an example of that. When you have a large lesion, you use a larger probe. For these are for these tiny lesions, I use a Q-tip, same as, it's used for cosmetic purposes. You dip it in liquid nitrogen and directly touch the keloid with it.
For how long?
And I have a session on cryotherapy. I'll go through all of the details tomorrow.
Okay,
but yes,
thank
this
you
is
very
just
much.
contact cryotherapy. And the duration of cryotherapy is depending on the size of the lesion. If you have a tiny lesion like this, it takes 10 seconds to freeze it. If you have that lesion on the ear that's 1 inch in diameter, that takes 10 minutes to freeze. So you just need to freeze the whole thing. Jonathan, you had
There was a question there.
Thank you very much for the talk. Just a quick question. Dr. Tirgan, you mentioned there's a mixture of 4 medications as a topical treatment for these patients with extensive keloids. I can imagine 2 of them being a steroid and a 5-FU, but I don't know what the other 2 are. So I'm just hoping you could shed some light on this. Thank you.
Yeah. The combination that I use is actually, I have a local pharmacy that kind of puts these drugs together. There's 6 drugs in the combination. One is triamcinolone, of course. The other one is celecoxib. Is a 4 anti-inflammatory drug. Fluorobiprofen is another one. Also, I add lidocaine to it. And I forgot the other 2 names. 2 other drugs for pain control. So 5–10% of patients respond to it. And that's the maximum response you get. So patients who have extensive disease, I usually start with. The other one is baclofen. You basically start with that. Say if you're lucky among 5% to respond to this, let's find that. Because somebody with that wide keloid on their chest, you're not going to be able to inject it effectively.
Sorry, just a quick follow-up question. For those who respond, do you normally achieve a complete response, or is it normally just a partial response?
Yeah. So that was one example that you saw. It's not a complete response. It's near complete response for that one patient. I have a handful of patients who have responded amazingly. I had that patient with that large ear keloid that I showed. She had a keloid in her pubic area, keloid nodule about almost 2 centimeters. And she actually got a vial of cream, a tube of cream from my office and self-applied it and photographed it. It took her about 10 months. That keloid became flat in that one patient with that massive keloid on her ear. And I have a handful of other patients who are repeatedly using it. The response rate to symptoms, the symptom response rate is somewhere about 40–50% because, you have lidocaine in it, you have steroid in it, it helps with the symptoms. Gabapentin is the other drug. This is the 6th drug that is in the combo. It helps with the symptoms. But 5–10% of patients have a response like one I showed you. And that's real. I have a handful of these patients. And that's what I used a lot during COVID because patients could not come to the office. So a lot more used.
So a quick question, Michael. So I'm kind of intrigued by the percentage that you see recurrence or that don't respond to all these cytotoxic therapies, whether it is radiation, cryotherapy, lasers, even cancer treatments. Are we missing something? Why is the percentage always about 15–20% that don't? Because all these therapies typically work by killing off cells in that vicinity. Are we leaving behind a specific pool of cells that comes back in about 15% of the patients?
The analogy of this is perhaps an analogy of malignant tumors. Malignant tumors are made of clones of cells, not one clone. So a cancer tumor that you see is made of tens of clones. You use your first-line chemotherapy, you induce some sort of remission, depending on what is the cancer that you're treating. You may even get to minimal residual disease in leukemias that you have killed of 99.999% of the cells. There's a tiny bit left. That clone will survive the treatment because it is resistant to that treatment. Then it's going to populate the tumor site. And the next line of treatment you use is perhaps going to work the same way, kill off some of that, and residual cells that are resistant to prior treatment will grow. This is true in oncology. I'm sure the same concept applies to keloid.
They're well-defined mutations that you can find in those different clones. One clone is different from another genetic. I have not found that in keloid.
Hasn't been studied properly. Who has done the study of using a biopsy? First of all, this is a very tricky situation, right? I'm telling you not to biopsy these, right? So you're not going to biopsy these, but ideally, yes, you need to understand that question. You need to biopsy that tissue first, look at genomics, look at all the markers, and many of these markers we don't even have right now. And then treat that patient, see if the patient responds or not. At the time of recurrence, you need to rebiopsy, then compare your markers. This is what we do in oncology. I mean, you start with the lung cancer, you biopsy it, patient responds to, because that's part of the protocol of treating the patient. You biopsy first before you treat. Here, we're telling you not to biopsy, right? There's a difference there. Then the cancer recurs, you biopsy it again, you find a new mutation, you drug that. The cancer responds and comes back, you rebiopsy it again. You cannot do that in keloid. I mean, you had the normal skin biopsy of what, several patients. I bet every site that is normal skin that you biopsied formed the keloid. Lamont presented that.
We have a couple of more questions because we're running out of time.
Yeah, we're running out of time. Let's, yeah.
Discussion is more important than time. So.
Sure, go. But you need to speak in the microphone so the Zoom audience can hear you. Zoom audience cannot hear you. You go ahead, please. Hi.
Thank you so much.
Of course, Anita. Thank you so much for joining us.
So would you mind sharing the treatment protocol that you do after you remove that keloid on the C-section that it grow back after they remove it?
So with that patient, I will be discussing that a bit more tomorrow. So I use let's call it intralesional chemotherapy. So you start basically with very low dose intralesional 5-fluorouracil. That is mixed with very low dose steroid. You try it once or twice, follow the patient every 3-4 weeks. If there is no recurrence, if there is no regrowth, you follow with the same thing 4 times. If there is no recurrence, you stop there. This particular patient, after 2 5-FU injections, there was growth of the keloid. The tissue was turning into hypertrophic scarring. So I added vincristine to that. You try that once or twice. If you can control the condition, you continue with the same regimen. If not, in this patient, we couldn't, we added a third drug, that is docetaxel. With that, she did respond. So she received 4 cycles of docetaxel with vincristine, with 5-FU, with triamcinolone in the mix. And then she had a complete remission several years ago. To this day, she is in remission in that area.
So the first injection you do is within a month or how long after?
3 to 4 weeks. After surgery, you mean? 3 weeks. After the sutures are removed, after the wound has healed.
Thank you. First of all, to the colleague from England, you said the magic word, experience, clinical experience. One thing. Second, everybody has an ego. The surgeons, the medical, the dermatologists, when the patient goes there, it's, oh yeah, I do this biopsy, whatever, right? No, it's okay, that's what I'm saying. No, yes, but look, the thing is, I always make this comment, where countries don't have lawsuits, it's different than like in the United States. You do something wrong, and the lawyer sometimes reads his book or articles, and they confront us. Why did you do this? Why this, that? Okay? No, one second.
The question.
Oh, I'm sorry. So all I'm trying to make a comment is that most of us, including me, we have egos. Instead of saying, okay, maybe could be this and that, let's ask at least another opinion, not just start doing this, that. And when there is a problem, nobody says anything. Okay, but what about this? It goes to a lawsuit and this confrontation occurs. That's what about practice.
Well, Dr. Tirgan was very clear about that in his talk this morning.
I'm sorry?
Dr. Tirgan made that very clear.
Yes.
Those doctors that were fooling patients and getting a lot of money. He made it.
Thank you.
He made it clearly.
Yes. Okay.
And I would like to ask Dr. Tirgan the following.
No. You are not in line.
No.
Thank you very much. First of all, a comment. One way of getting around all the this ego, etc., with all the data we have, maybe we should bring on a little bit of machine learning and AI to help those with lesser experience. But my question was, we've not talked about the natural history. And in the data from the questionnaire, where almost a quarter of people got worse after laser and so forth, was that not just progression of disease? And how can you actually distinguish from the natural progression of the disease and it being made worse by an intervention?
Absolutely. That's an excellent question. The set of the 300 patients with ear keloids, I cataloged them, and none of the patients who had no surgery had any keloid that would be larger than 1 inch in diameter. It just, in my data set, there was nobody whose keloid was smaller than 2.5 centimeters who had had surgery. And when you pass that point of 2.5 centimeters and up, all these patients have had surgery. That data I don't have, but I showed you that one patient with very large keloid on her ear, and you saw how small they were when they had surgery. And it's very hard to collect all of this data, but typically the keloids, ear keloids in particular, they don't become very big if you leave them alone. I don't know, from your experiences who have treated patients with ear keloids, how big have they been left untreated that you have seen in your practices? What's a Lamont?
They can get big.
Untreated.
5 centimeters, 6 centimeters, I've seen it.
Untreated.
Untreated.
Okay. Have you seen anything that's bigger than the size of the ear untreated? Bigger than the size of the ear untreated. Okay. You have seen, how many of those have you seen? Okay. At least, sure. Definitely. And in the data set of the patients with neck keloid, I showed 2 or 3 patients who did not have had surgery, correct? But they had massive neck keloids. So the point is well taken. We don't know. Those who have had surgery, we don't know how big their keloids were in the past, how small they were. So that's a point that we have made previously, that we need to have an ongoing open keloid registry, that every keloid patients get registered there, photographed there, full history is taken and followed longitudinally to see what happens to properly answer your question. But
yes, thank you so much for sharing all your experience with us. I was wondering, do you use or see any room for shared decision-making with the patient? Do you tell about the different treatments and let the patient's opinion also influence your decision on the treatment you choose?
Is your question that, do we ask the patients what their preferences are?
Yes.
In terms of treatment? You should always ask that. But if a patient is willing or wishing to have surgery, say, of course, I refer them to surgeons. I have a handful of patients who come to me and say, oh, I'm getting married next month and I don't want this on my ear. I said, well, I cannot do much for you. I refer you to a colleague of mine who is a...
And if you need to choose between intralesional injections or cryotherapy, is that something also you let the patient decide?
If there is recurrence after that, depending on the area of the body where the keloid is located. Ear keloids in particular respond extremely well to cryotherapy. Cryo alone, without anything else. Other parts of the body, it's a different story. You have had patients who have had chest keloids that I've treated them with medical methods, and then I have referred them to surgeon because patients get tired. So what's the next thing for me? Last week, I referred a patient, a female patient in her 50s, who had a lumpectomy for breast cancer and had developed a keloid at the site of lumpectomy. And she had full dose radiation to her chest. She also had a keloid on her shoulder that was removed once and had recurred and didn't respond. Many of them didn't respond to medical treatment. I did refer her to a surgeon for surgery and radiation.
Yeah, I'm a plastic surgery resident, and we see a lot of keloids in smaller hospitals, but they're smaller keloids, and but it's quite difficult because you really need your experience with treatment and how different keloids respond to it to actually give good patient information to your patient. I think.
Correct.
Yeah.
But there's not that much to choose from, unfortunately.
One
question.
Sarah, I just want to take you back to the question before where you were asking about how big do they get without surgery. In my case, I found that pre-surgery, they get quite bulbous and quite big, but post-surgery, they come back. Even if they come back bulbous, they're not as bulbous. Sometimes they're, especially if I have post-surgery with corticosteroids or 5-FU or triamcinolone, then it comes back much flatter. It does come back wider, bigger surface area, but usually not as high. But they usually they can get very bulbous even without doing anything. Very big, very bulbous. They grow at whatever rate they want to grow at.
Okay, last question for you, John. I don't mean in total, but for this session.
Very short. Dr. Tirgan, thanks very much. What you have to be clear is, and I've watched Dr. Tirgan give cryotherapy. He does it beautifully. But what he doesn't tell us is how many repeats he has to do. If you imagine he does it in one treatment, no. It's repeated. It's fractionated, correct?
That is absolutely
And that's not clear. It's fractionated. They come back to New York and back to New York and back to New York from all over the world because he's got a wonderful reputation, and quite rightly so. We can't have a cosmetic effect as he does without anything just cryo. But he has to make it clear to you that they're repeated cryo. You may get the impression when you hear him, that it's just one treatment, but it's not. He shrinks it a little bit every time. So it's repeated fractionation. Now, Dr. Tirgan, laser beam is 1,000 degrees hot laser. That doesn't go with keloid. They get worse with laser. You burn them. Keloids don't like to be burnt. They grow. They get nasty. One other thing I want to tell the lady that asked about the size of the keloid. The lady asked, you asked, what you've got to know is everyone photographs with their iPhone. I asked the patient, what did it look like before? Oh, doctor, do you want to see my iPhone? Of course I do. And then I photographed the picture on an iPhone. They all got a record of it. The iPhone is marvelous. Well, you know, the ability to... So, Michael, ask your patients for an iPhone image.
Absolutely. I just respond to one of your comments. I have a whole session on cryotherapy. I'll go through all the details of how it is done, how frequently it is done. I couldn't include that session in this session here. Then this is just a strategy session, and this was a strategy of how to treat patients. This is not discussing how to use cryotherapy. This is not discussing how to use chemotherapy. As you notice, I skipped through chemo. I just mentioned chemo. When the question was asked, I went through. So I have a whole separate session on those, and you're correct. Chemo cryo is repeated.
Thank you. Fantastic discussion.
That's very good.
I think we shouldn't have any presentations, but only discussion, right? Because we do have so different opinions and we can learn so much from each other.